So we'll start, as you ask, about our experience in Italy on COVID infection in children. Am I correct? Hello?
Yes, please go ahead.
Okay. So I just want to tell you that we were struggling actually since the beginning of March with this terrible infection. And fortunately, I have to say that the rate of the pediatric infection is very low, as reported all over the world. The government in Italy organized the assistance, creating for the adults some hospital dedicated to COVID infection. That means that some hospital have a wing that they concentrate all the COVID patient. Moreover, they stop all the other consultation and of course, all not is an emergency, you know, all the routine surgery or all the routine outcome consultation. So situation is like during the war. Almost everything is blocked since the beginning of March. And since from Monday, 4th of May, next Monday, we will reopen to do this. So let's go back to the infection in children. So fortunately, infection in children, it's also in Italy very low, symptoms or fever, then they should have to underwent to the swab test to detect the coronavirus. And this is not possible because I don't know how is your situation, but all over the world, you cannot just swap all the people getting to the hospital. Moreover, now it's very difficult also entering into the emergency. So it's like a pre-triage, like a tent camp for COVID, you know, and this makes a lot of missing cases, especially the asymptomatic. And this is the reason why the infection is going to spread all over and over with high number. But go back to the children, what we have so far, there are some studies that have been publishing. So the one that almost all of you know is this one coming from China, where they reported epidemiologic criteria to diagnosis, but of course this was related to Chinese population. What is interesting in this study, that is of course done on 2,100, almost 2,000 children, is that the children in the age range from 6 to 10 years seems to not have any intensive care necessity of therapy. That means the severe case of coronavirus in children is almost belonging to the adolescent age, so means from 11 to 15 years, and also reported from the children below 1 year of age. Actually, in Italy, we have very, very small amount of cases in children. Maybe we should have no more than 50, 60 children affected by COVID that without any needs to go in the intensive care unit so far. I'm talking about the Italian experience. And so we have also some maybe 30 or 40 cases of newborn born from a COVID plus mother, a COVID positive mother, but all the newborn are fine. All the newborn get the swab, get everything, and everything is fine. We didn't have any child death for coronavirus so far in Italy. While we have ones in Belgium and one in France, another one in England. In Italy, we do not have any death in children. So therapy for children is almost the same that we have. And now, I'm sorry, I want to just tell you something about why this is so in children. I mean, why the children get a very low rate of infection and get also a very mild symptomatology. This, it's only speculation because we don't know almost nothing of this virus. Now we are getting familiar with him. We are studying. Now they discovered about this immunity that lasts forever. And, you know, we are knowing, we are facing this virus. We don't know him, so we are studying. So there are some speculation why the children don't get this strong infection, these strong symptoms. Because as all of you know, the severity of the symptoms of coronavirus is mainly due to the inflammation and the cascade of cytokine, and also this interstitial inflammation who just provoke pneumonia. And so maybe because the immunity, the immune system of the children is more resilient. We will talk in the next speech about this plasticity, and so they have also they don't bind receptor of ACE2 inhibitor. So moreover, the children also have immune system this already trained, let's say between bracket, it's already trained fighting the respiratory infection. So we don't know, we speculated, maybe this is one of the reasons, maybe not, we don't know. So what we can do as a treatment for children. So what also this has been changing. We are dealing, I mean, at least in Europe, in Italy, we are dealing with this infection since the beginning of March, so almost 2 months. And in adults, they use now a very high dosage of cortisone. They use heparin for anticoagulants because almost all the deaths are due to the septic shock or to this coagulation problem. And for children, they use some use nebulized interferon alpha and some antiviral like lopinavir or ritonavir. And we use definitely corticosteroid. And corticosteroid now in Italy, the experience in Bergamo, where they had only in a region, a small region of Italy, they had 13,000 deaths so far until today. All over Italy, we had almost 28,000, and almost the 50% is in this small region. So it's all concentrated there. And cortisone has changed a little bit the history of this disease. We use prednisone, and now they are using intravenous immunoglobulin for the severe cases. So this is almost the strategy we are using, the therapy, but the success of this slow rate is that we are not, since March in a completely lockdown, completed. So schools are closed, children are stuck at home, and they don't see grandparents, they don't see uncle, they don't see family. They just stay with their mother and father. I mean, I don't know, in Italy, especially in the South, we are like you in Middle East, strong family, big family, people gather together for any reason, anytime. And so this maybe is one of the reasons we control the infection, at least in children. So now you ask me whatever doubt you have on this and if I can help you.
Yes, we can hear you.
Okay, so
did you use any medications? Do you do regular swabs for suspected cases? Do you do something in specific when it comes to therapy options?
No, unfortunately, we have a lot of problem doing this the swab to all the population. So children get the swab only if they have a severe respiratory infection and a high fever and they go to the emergency hospital. Otherwise, no. And no, we have problem also performing a swab to the people who are to the healthcare professionals. So now they are starting, but this was the main problem of Italy. because at the beginning we were unprepared. We were absolutely not prepared to face this emergency. We didn't have so a high amount or sufficient amount of reagent to perform the analysis of the swab, but now it's going better. That's why a lot of data, especially from the oldest people. That's it. May I read some question that I have it here in the chat? So are the swab a child born to positive mothers turned out to be positive with mild symptom, or the swab are negative? So, so far, all the children that have been born to a positive mother, they had a negative swab because they get the swab, all the children born from positive mother, and all of them were negative. So what is the percentage of cure among children? Almost 100%. No, we didn't lose any child. Do you think that vaccination as a rule making symptoms to be mild? Yes, this is one of the possibility, because I think as all over the world, we have compulsory vaccination against almost everything. And so children got all the vaccination, and this could be a possibility to modulate the immune system of them. Let's say it seems that, what about the use of antiviral in children? Yes, we do use specific for the COVID, but mainly the success of therapy is not mainly due to antiviral, but it's due to reduce the complication of interstitial pneumonia or coagulation problem. About plasma treatment in, no, wait a moment, I lose some, wait a moment. It seems that there is some genetic difference in clinical presentation, because in the Middle East, most of it are asymptomatic or has mild disease, while in China, many patients need intensive care. But this is for the adults, is not for children. The problem is, I don't know how Middle East is facing. I don't know how many swab you had. I don't know what is your observatory. I mean, the epidemiology you are using, and this is absolutely depending. For instance, if you do 100,000 swab per day, and of course you have a percentage higher. I cannot explain, but I don't think it's related to genetic. It's a matter of surveillance, clinical surveillance. Plasma treatment in children is better immunoglobulin. It's good to meet you. As there are any new case of Kawasaki, any specific therapy? Okay, this story of the Kawasaki was reported 1 cases, because as you know, this COVID infection gives this vasculitis, and sometimes it's impossible to differential diagnosis with Kawasaki. It's only 1 case is reported in England, not really clear. So the correlation between immunity, I already answered. Do you give steroid by nebulizer? No, no. Steroid IV or oral. Do you use hydroxychloroquine? No, neither in adult nor in children. Because look, I want to tell you about this, about hydrochloroquine. Hydrochloroquine is an old drug. We do have antibody, monoclonal antibody anti-TNF alpha. We have a very strong weapon. It's like you have a Kalashnikov and you use the arrow. This is the difference. Why do you use, we do have to use hydrochloroquine if we do have monoclonal antibody that just have a very strong effect on blockage of the cascade of immunity. What about sensitivity of swab test? It is similar, completely similar, completely similar. The sensitivity of the swab is it's the role of vaccine against COVID. No role about this vaccine on cock bacilli. No. Do you have a protocol for children? I told you already, this is the protocol of children. You get the swab, and then they are monitored in this special COVID hospital. We do have, I'm working actually in my university, there is this pediatric hospital. So we are only pediatric, and we have a wing for COVID. Do you have specific doctrine then? These cases of skin lesion is growing and growing, because has been reported a lot of cases with skin and that were positive to the swab. This would be possible as far as the disease. It's especially the complications are due to this immunology cascade. So could be possible, but they are not diagnostic. What I mean, you cannot go and make a swab to a baby who has lesion on the skin, because then should be monumental. Then you need million of swab. From UK, so prednisone for any positive case or only for severe? Well, not for positive asymptomatic. Positive asymptomatic, they just stay under control. And now in Italy, especially the adult, they go home to make this surveillance by the family doctor, the family practitioner. They don't stay at the hospital neither. If they have a very mild or asymptomatic, even with the swab, they've been got in quarantine. They cannot go out from home at all, and the doctor goes to them. No, it's not transmitted to the breast milk. This it's already been shown. All the mother COVID plus that make that deliver a baby, they can breastfeed without any problem. About cesarean section, what about this? Is early or only late stage of disease? No. Just the pregnancy came follow the normal route. If the mother have to go to vaginal delivery, she get vaginal delivery. If there are, the indication for C-section of or vaginal delivery is not up the COVID of the virus. What about vaccine? I told you already. What about breastfeeding? I told you already. What about breastfeeding? I answered already. What about congenital infection in the mother? Any reported cases? No. So far, any. After all, I told you about this vaccine, no rule. The vaccine needs to be for the virus. We cannot rely on any vaccine we have. I guess we can, but we cannot. Was radiology of CT scan in children similar despite mild clinical symptoms? The radiological findings, CT scan also in children is also the same, interstitial pneumonia. Interstitial pneumonia. 8%, 100%. Why we use medication? We use medication because we want to prevent the complication, and because this complication just can come unexpectedly. So you have to monitor, use corticosteroid, you monitor the situation. Did you use hydroxychloroquine? I answer. Strong and immune play a role. Yes, I told you I answer. If child is asymptomatic, do we to give X-ray? No. We don't need X-ray if the children is asymptomatic. About diagnosis depend on PCR or CT. Diagnosis depend on the swab. PCR, that's it. You cannot do a diagnosis with the scan lung, with the ultrasound, with CT scan, whatever, because as you know better than I know, pneumonia have a lot of similar. You cannot recognize only in a specific case, you cannot recognize the difference. So you do need to have the PCR. What about the Italian management protocol? It's the same that to show or modified. I told you we modify. That is not my own, my personal experience. This was reported by some friend of mine who worked in a COVID hospital in Bergamo, where we have the highest rate of death and also of disease. They change a little bit the dosage and the length of cortical therapy. So we do not follow the protocol of WHO. Famotidine in treatment, I don't know. I cannot answer this question. We don't not use, never used. because in most center in adult, I think it's the only late stage about corticosteroids. It's only in late stage. Yeah, I explained this about corticosteroid. We are always in question with use of steroid if any antiviral. I told you, vitamin C, zinc role as immune booster for COVID positive. Please, more than this, a role has been set for vitamin D, because this modulate immune system. Long of acting corticosteroid in early treatment, I answered. What about oral fecal transmission? The answer is no. The transmission is by air. So respiratory tract, that's it. No other way. Why severe was more severe in infant compared to older children? Well, this is the severity of COVID in children. We do have only one publication done with this in China, and they reported this different age rate. So you have these children below 1 year of age, they had severe symptoms, and then on the adolescent. I don't know why, nobody knows why. Can we use monoclonal antibody in children? There is, they're still off label. No, they're not recommended. In Italy, we do not use, because there is no severe cases of complication. This I answer. Already taken. No, this I don't know. Presentation arm. I answer to this. In Iraq, that rate is very low. What do you think about, please? I don't know. Cannot answer. I don't know how is your surveillance. I don't know. Did you test all the people that died? Did the test? I mean, I don't know. I don't know how is the situation in Iraq. I cannot answer. I have almost 100 messages. I think we can stay here for another hour to talk about this. What about L. asparaginase? I don't know. This I answer. What is the main complaint of COVID you find in children? I'm not working in the COVID wing. So, okay. Okay. I'm receiving a message that we have to switch to the main presentation. So maybe we can continue because I have almost 100 questions so to answer. And then Mohammed, maybe you should introduce me again.
I think we can jump over some questions. Probably some are repeated. We can check at the end as well. We still have time to have more questions, be it on the earlier clinical topic or the main probiotics immunity topic that you will take us through now. And I think Professor Flavia is the best one to talk to us on probiotics and immunity, L-reuteri. How can this impact the immune system of infants and children? So I will be listening very eagerly to your presentation, and I think everyone as well will be listening to your engaging presentation with the new studies, with the new data that you'll be sharing with us today.
Okay.
Thank you, and please go on.
Okay. So we switch there, and then at the end we can also ask, because just today was released a statement from ISAP, the International Society of Probiotic and Prebiotic, about the use of probiotic in COVID infection, but of course in adult. In any case, let's jump to this presentation, but I cannot find the arrow anymore to move. Now I found it. Wait a moment. I cannot find the arrow. Can you see moving? Because I'm having problem.
Yeah, it moved. I think we can see the second slide.
I'm having problem for moving up and down. Okay. But can you see the slide? Okay.
Yeah.
Okay.
Yeah, I can see it.
So, okay. So we will talk about, as you can see, the title. I'm sorry, I had some problem. Can you see me? Okay, now I am. Okay, everybody ready? Okay, perfect. So the title of the speech is Shaping the Immunity with Probiotics. So I will focus on the microbiota and intestinal function, especially the immunity, and the relationship between the microbiota and the gut-associated lymphoid tissue, and the general immunity crosstalk, and the effect on probiotic on immunity. So why it's so important is, so it's important to know that, of course, everybody of you know that the intestine is not a simple digestive and absorptive organs, but carry this big amount of lymphocytes that get as a major function of the intestine and the crosstalk between the microbiota, just controlling the innate immunity and the adaptive immunity, and also all the metabolomic and the bioreactor. But as you can see here in the slide, there is a difference in the different tract of the intestine. That means the ileum and the colon. And this is also related to the fact that we found the microbiota distribution totally different in the different tract of the intestine. We have a very high number of bacteria into the mouth, but then we have a low number in the esophagus and in the stomach, and then they start to increase in the small intestine and into the colon. And also what is changing is the rate of the phyla, the distribution of the phyla. And why is this? Because as you can see in this slide, we have a different pattern of intestinal immune cells into the intestine. We do have, especially in the colon, where there is the highest number of microbes, of microbiota, high density is in the colon. We do also have there the highest number of lymphocytes, the gut-associated lymphoid tissue, that are located there strategically. But let's go and magnify this in this cartoon. Look at this. These are the villi, and this is the submucosa, and this is the patch of Peyer, or the lymphocytes of the intestine are located here. And what exactly is this? So we have this area that of the contact with the microbes and the lymphocytes. Look, and then if we go and see what's happened in the vessel, there is a strong net between the lymphatic capillary vessel and the blood vessel that just carry all this product of elaboration of crosstalk between the immune cells of the intestine and the microbes to the blood system. Not only, also to the lymphatic system, goes directly again into the blood system with the ductus, lymphatic ductus. So that means that all the stuff that is happening into the intestine goes in the blood vessel circulation, and this means that can reach all the organ in our body. That's why it's so important to keep safe and functioning all the intestine. Why do I show you this slide? Because in this slide, it's show how complicated and complex is the gut functioning. We do have the immune system all over here with the dendritic cell. We do have in the lumen all the bacteria. We do have all the neural cells, intestinal neurons that are in contact with the immune cells. And we do have also this, that is the zonulin, all the intestinal permeability within the protein that are strictly regulated with the interaction of these bacteria. But what exactly happening when the baby is born? All the fetus is born immune suppressed. So we do have a baby that is not immune deficient, but immune suppressed because he had to survive in the womb of the mother. So they have also a paucity of microbes. So this immune system, especially the innate immune system, need to be developed. And this goes together with the colonization of the intestine of the newborn. And also in this first beginning, when the baby is immune, the newborn is immune suppressed, all the process of this intertalk between bacteria, but not only the bacteria, also the metabolites of this bacteria, shape the story of allergy and autoimmunity, because in this moment and in this place is creating the immune tolerance system. And why is extremely important? Because as you can see in this slide, the intestine has always have a steady state inflammation. So the intestine have an inflammation that is stable. But this stabilization, this balance of the inflammation can easily go to an overinflammation with the production of cytokine and other processes. They can increase all the process of immunity also far away from the intestine. And this is strictly regulated by the crosstalk with the bacteria. And these bacteria, as we know, change during the first months of the baby. So we have a small amount, the newborn have a small amount of lymphocyte and a small amount of bacteria. And over, how the increased colonization of the intestine make a part, so increased number of microbiota, differentiation of different strain and family of bacteria, so they are increase also the lymphocytes, the number of lymphocytes. And in this very moment, in this regulation, start all the process of acquisition of immune tolerance. And if it's disrupted, if this balance is disrupted, that starts the basis of autoimmune disorder. Because if the gut microbiota is dysregulated or creating a dysbiosis, then this easily happening that all the process of inflammation make the state of unbalanced inflammation. But when this process starts, this process of regulation is not starting at birth. I should say that it starts since the beginning of pregnancy. So the mother have a role in this modification of the immunity and the colonization of the baby. So it's extremely important to take care of the mother during pregnancy, also with nutrition, because during the pregnancies and during all these 9 months and this famous first 1000 days, start all the process of epigenetics. So nutrition, microbes, and epigenetics make the difference in our health later in life. So this is called also the rule of the programming of microbiota. So we do have our genotype, but this is changing not only with our birth, so kind of birth, maternal factor, mode of delivery. And this is extremely sensitive. All these processes are extremely sensitive during this first 1000 days, because this is the window of opportunity, the critical window. Why? Because at 2 years of age, when the 1000 days are almost ended, the microbiota is settled already as the adult life. So we have a slow changing of the microbiota after 2 years of age, while we have a high possibility to shape and change the microbiome during this first 1000 days. So this complicated interrelationship has been shown in one of our papers. We just get together neonatologists, gynecologists, pediatricians, just to understand how the maternal nutrition, the child nutrition change the microbiome. Nutrition can change microbe, and microbiome can change the expression of the genes. But how can we do? I mean, why is so important the rule of nutrition? Because as you can see in this slide, there are a lot of factors that can change the microbiota concentration. Drugs, hygiene hypothesis, all of this. But what we do, we eat 3 times a day. So the stimuli that comes into the intestine is with nutrients, it's an overload immense that cannot have any comparison with use, for instance, of antibiotics, because antibiotics we use one week, 10 days, then the microbiota can recover. But the diet is every day. The diet is every day, 3 times a day. So it's extremely important, the rule of diet. And what about nutritional supplement in inducing eubiosis? We have a lot of possibility of using kind of nutritional supplement. One is the prebiotic, other probiotic, and other the postbiotic. But tonight we will focus on the probiotic. The probiotic have a definition. This was the last one. That is a statement by the International Society of Prebiotic Probiotics. Again, this is not in pediatric, it's general, also for adults. And the definition is this: it's a live microorganism that, if subministrated in an adequate doses, have an healthy effect on the host. So this effect, this healthy effect, needs to be demonstrated. And also, to define a probiotic, the probiotics have to have activities, have to be from human origin, not pathogenic, have a resistance on the pH of different pH of the stomach and of the intestine, have to be, but more than other, they have to have an immune modulation and a metabolic effect. But not all the probiotics are the same. And again, in the definition, I'll show you that have to have a beneficial effect. So we do need to have a strain specificity effect and an adequate doses. Tonight we will focus on this strain of lactobacilli, that is the I'm sorry, I just make a mistake. So we will focus on this Lactobacillus reuteri. This is a strain that colonize the mucosal surface of animal and have a unique and strong host specificity. So it's we find in the mother milk, in the vagina, in the small intestinal, in the oral cavity, and the mother can transfer this to the baby. That's why it's so important also to have a possibility effect on the pregnancy, starting from the pregnancy. So this strain, because we have a lot of Lactobacillus reuteri, what we need a specific strain, that this is this 17938, was found by Professor Reuter, isolated, first identified as fermentum, and then classified as reuteri in the 80s, and was isolated in human, because as you remember, in the list of activities is written that has to have a human origin, was isolated from a breast milk of a Peruvian woman by Dr. Casas. And then there was in 2006, a plasmid that carrier resistant and antibiotic resistant was cured, and then was designated as reuteri DSM 17938. So what is the evidence? Because as I told you, we do need to have a beneficial effect. But as you can understand, to show this effect scientifically and a scientific study on in vivo or in vitro, you know, biological laboratory, because we cannot do this study in human, and less than ever we cannot do it in children. So there, I want to show you some biological and scientific, you know, basic study on how this strain of reuteri just increased tight junction proteins between the epithelial cells that make the intestine very strong to not enter the pathogenic or other, or to create this oral tolerance. They increase also the mucous thickness, decrease the epithelial leakage, and protect the mucosal barrier against the deleterious effect. All these studies that I'll show you are done with Lactobacillus reuteri. This is one scheme of the layer of the mucosa. So we have the mucus, we have the epithelial, and we have also the possibility that reuteri can protect this barrier. What has been showing with different studies? This one study was published by this scientist Karimi, and they just protect the infection of E. coli with the tight junction. Just they use it, the Reuteri, on the mucosa, and the mucosa was very strong, you know, to protect the epithelial from the this kind of infection of E. coli. Another study just also showed that this kind of strain just thickener the mucus. The mucus protect the epithelium. So these all studies are in vivo or in vitro, not in adults. And this is a quite new study published in this last December, that they reduce the inflammation of the mucosa and also reduce the permeability. So what we can conclude, that definitely the preclinical study strengthen the different layer of the mucosa and reduce the mucosal damages of the inflammation. Okay, everybody happy, everybody agree. So this strain is working. But what is happening in children? We are pediatricians. We want to know what's happening in children. So this is, I show you now, it's an old study. This was published in 2010. And this was done by Dr. Rhodes, and he say, okay, this was done on colicky baby, and say the colicky baby has this inflammation of the mucosa. How can we test? Because we cannot go and make all the study I show you before in children. So this Dr. Rhodes took the calprotectin of the, just without Reuteri, they just say, okay, the baby with colic have inflammation. How can we detect? We detect inflammation just checking fecal calprotectin in the stool. Very easy, very simple. And what he found was that this level of calprotectin was very higher in infant with colic than in control infant. Okay, we are happy with this, but what Reuteri does to this inflammation of the intestine? Makes something difference? This was a study published last year, 2018 exactly, so 1 year and a half, by Dr. Savino. What he did, he say, okay, we treat this infant with the lactobacillus reuteri. We know that this colicky infant have inflammation. We treat with Reuteri, and we check the receptor of inflammation and the FOXP3, and also the epigenetic, the expression of this gene. So he randomized the baby 32 plus 28 to receiving or not the strain of Reuteri. And what he found was the difference, extremely different. So the baby that were treated by colic compared to placebo had a difference in the expression of this receptor that are the blood inflammatory marker of inflammation. So there was a modulation of inflammation by the Reuteri. And this was done from the day 0 to the treatment to the day 30. So look, this is the placebo that was on the contrary, and this was the high level of the expression of this receptor of the inflammation. So this effect of the strain. Okay, so everybody happy, but we need to know immunity. So we know this strain have a role in changing the inflammation of the mucosa. Okay, we are happy with this. But how can we use it this far away from the colic on the immunity? So what is the thermometer? What is the modulation? What is the surveillance of immunity? Infection in children. So infection is the leading cause of morbidity and mortality in children. So we have diarrhea, respiratory infection that cause illness, death, mortality. Children, it's 5 to 10 times higher, imagine in the developing country, but also in our country that are a little bit wealthier. So we have problem with this continuous infection of children. And also the infection need the protection by the immune system. And so I show you how this 80% of the immune system, the innate immunity change the adaptive immunity. So an infection on children that have an undeveloped immune system can be more sensitive. So also the children that go to the daycare school and they mix with all this microbe together. So the modulation of the immune system of the children is extremely important to prevent infection. But Again, let's go back to our strain, to the Reuteri. There is any evidence that this strain is changing and protecting from infection, modulating via the intestine? There are at least 3 studies that has been published so far, 3 double-blind randomized controlled trials, one that checked the reduction in diarrhea and respiratory tract infection, the use of antibiotic, the reduced absence from daycare, and the cost saving for both family and community. And what are these studies? One was published a long time ago, in 2005. You imagine that people almost were unaware about probiotic, and was done by Professor Weinsmann, and he showed in these children in the daycare that the children treated with Reuteri had a less day of diarrhea, a less day of antibiotics, less day with fever, and less day of absence of daycare. He didn't check respiratory tract infection. Then there was a more recent study done in Indonesia by Dr. Augustina, and she checked in this underdeveloped country, the children with diarrhea and less antibiotic use with supplementation of Reuteri, 250 children. And then this last in time by Dr. Gutierrez in Mexico, he checked 336 children, randomized with receiving Reuteri or placebo. And what he found was that these children who received the supplementation of Reuteri had less day of diarrhea, less day of antibiotic and fever, and absence from daycare and respiratory tract infection. But these are almost all studies. What I want to show this, it's almost published a couple of months ago. And this is a supplementation of Lactobacillus reuteri in mother and in children, and an effect of expression of immune maturation, epigenetic process, and development of allergy. I want to tell you some word about this DNA methylation. The DNA methylation they checked is the main process biochemically that happens during the epigenetic changes. That means that bacteria or immune cells can change the expression of a genes. So what these scientists, this group of Sweden did, they supplemented the mother since the gestational week of 36. So they also supplement the child until 6 months, and they check the baby until 2 years of age. So they check the blood with cytokine, the cord blood, and also they make at 1 year and at 2 years. And also they check the purification of the lymphocytes, they extract the DNA, and they check the expression of the genes. So the children, the mother received, and they were followed until 2 years of age. What were the results? Look at this. These are some cytokine. Again, the FOXP3, that is a receptor of inflammation, and this the interleukin 13, 17, and another factor of inflammation. What do they found? That the baby who were receiving the Reuteri had a modulation of inflammation much more than the baby had without Reuteri, with the placebo. So they demonstrate that the perinatal probiotic supplementation affect the DNA methylation of the CD4 cells that are the lymphocytes that are related to the immunity system. And this effect, of course, is more pronounced at birth. And also the genes in the module were hypomethylated, suggesting that the probiotic may mainly lead to a transcriptional activation of these genes. I want to make clear this concept. What is exactly this? So the genes, when they have to be expressed or produce a protein, can take a street or another street. If we have this kind of bacteria, the Lactobacillus reuteri, they take the right pathway to create a T cells receptors to signal differently, to signal properly, and to make a crosstalk with the general immune system, and to create an oral tolerance immunity system to prevent allergy, or just to mature the immune system to reduce the sensitivity to the infection. So what we can conclude, that microbiota definitely shape the immunity in children, that there are multiple strains of probiotics, and the effect is strictly strain dependent. Please, I will never be tired to repeat this concept of strain specificity. And this strain of reuteri has an impact on the intestinal inflammation state and plays an impressive role in preventing infection and modulate allergy. And with this talk, I just say, we are Italy, we will meet again, and thank you very much for your attention. Hello, can you hear me?
So thank you so much, Professor Flavia. We probably were so engaged with your session and your talk. Thank you so much. Probably we'll be having some time to get some question and answer. So please open your Q&A.
I am already on my Q&A, but that's again another 100 questions. So
yeah, there are two buttons down, one the chat and one the Q&A. So let's start with the Q&A one, and hopefully we get the most common ones.
Let's go to the Q&A.
Exactly. So the first one probably is, what's the best probiotic for gastroenteritis? What's the role of probiotics in infantile colic?
I am. Is the premature? Can we talk?
Yeah, there were a couple of questions earlier as well. Yeah.
Which is the best probiotic for pediatric gastroenteritis? So I'm happy to announce that yesterday were published the new guidelines of ESPGHAN, and I am one of the author. And reuteri is one of the three, together with Lactobacillus GG and Saccharomyces boulardii, and reuteri for pediatric acute gastroenteritis.
Great, that's good news, I think.
Yesterday. We're published
just 2020, yesterday. So it's just a fresh thing that we're getting.
Yesterday we're in Medline. So you can find it on JPGN.
So we'll start searching for it from now.
What is the role of probiotics in infantile colic? What is the best probiotic for infantile colic? Definitely with no doubt it's reuteri. There are hundreds of meta-analysis, so no doubt. Why they call the gut by the name enteric nervous system? No. The gut carry the enteric nervous system. The enteric nervous system is done by neurons that are located into the gut. So is the premature baby has optimal microbiota? No, the premature baby do not have ideal probiotic. We do have to give probiotics to them. Also to this, there is another position paper that was published on February on probiotics to prevent necrotizing enterocolitis. You can find also this paper on JPGN. Now this is on constipation, and this is another topic. So we can use it for 3-4 months, but this is not the treatment. But now I also can, if I can tell, if Mohammed allow me to tell, that soon will be published the Middle East guidelines with probiotics also in constipation.
Yeah, hopefully soon will be out as well.
Also, how can fit viability of probiotics for a long time before consumption? You have to keep in the, you have to follow the indication of the packages. I mean, because there are different kind of probiotics. You can have it in powder, you can have it in drop, you can have it in tablet. So you have to follow the industry information. How long this is colic? Again, I send you back to the guidelines. Can symbiotic be more beneficial, probiotic or prebiotics? Look, symbiotic, prebiotic, postbiotic, prebiotic, whatever, you need evidence. You need to demonstrate. So there's nothing that is the Harry Potter of the nutrition. You do have to demonstrate whatever you want. You want the intestinal permeability with the symbiotic. Is there any study? Okay, we can use it. There's no, we not. So understand, children, again.
Yeah,
COVID.
I think you were always also mentioning the strain specificity. So we no longer say probiotics or prebiotics in general or anything in general.
There are enroll probiotics, lower blood cholesterol level. There are some studies in adults, also in obesity, but nothing, it's really scientific evidence. As we know, the probiotic increase the gastrointestinal and the COVID affect respiratory system. So, thank you very much for this answer. Ahmed Armin, this is a very, very nice question, because again, a couple of hours ago has been released by ISAP that there is no role, any role of probiotic or prebiotic in treatment of COVID-19, any, so far. So how many days use of probiotic in the use of PC? What is PC? And children and the age of use, what is PC? I don't understand.
Maybe BCG, is it?
No, it's written PC. How many days of use of probiotics in infants and children and the age of use PC? I don't know. When does an actually COVID-infected child become swab positive? After 14 days of incubation, almost the same. Any children presented with gastrointestinal symptoms? Yes. With COVID? Yes. Gastrointestinal symptoms you can have abdominal pain, you can have diarrhea, and this is another proof that intestine is absolutely involved in the role of the immunity. So integrity of the intestine can make a difference. I read an article about use of probiotic in physiological jaundice. I wrote a paper with the use of prebiotic in physiological jaundice, and we find that different, but it's very old. Now they just, they don't feel anymore a danger in the neonatal jaundice. Any risk of probiotics in an immunocompromised child? The answer is no. If you just consider that the premature baby are immunocompromised, especially the very tiny premature baby. And the other question related is use of probiotic in preterm baby to prevent NEC. There is a guidelines of ESPGHAN published 2 months ago in February. And also I am one of the authors. So go and download. There are a lot of information inside. It's better to use one type of probiotic or multiple one, evidence-based. You need science, you need papers. So it's not a matter of one or multiple, it's again strain specificity. Can we use in acute or chronic gastroenteritis? What do you mean? Acute gastroenteritis, yes, there is the guidelines. Chronic, it's a wide expression. Duration of probiotic in infantile colic. Yes, of course, they at least minimum 1 month, also 4 or 5 months. You say the fetus has suppressed immunity. So what about premature baby? You can give probiotics, as we know they have lower immunity. Look, the baby born immune suppressed, but this doesn't mean he keep immune suppressed. They need to develop, and this happens in the first 7 days. And of course, this happens at every age of gestational age. So we do need to give probiotic to the baby just to modulate this development. Is inoculum size of rotary matters? It's not an inoculum size. When we speak about dosage, we have to speak about a colony forming unit that is specific for any probiotic. What is the role of probiotic in the treatment of diarrhea? They just decrease 1 day of diarrhea. Can we use...
That's a lot, I think, when the average diarrhea is 4 days, so that's...
Yeah. Can we use a prophylactic Can we use as prophylactic therapy to prevent infection in gastrointestinal and urinary tract infection? Yes, but I show you, these are studies in prevention in gastroenteritis, not in upper respiratory, but not urinary tract infection. But there are a lot of studies that are also showing that they can help, also in the prevention of so how do you explain the possible steroid treated viral infection? Again, when we use steroid in the COVID infection, we are not treating the virus. We are treating the cascade of inflammation that this virus provoke. That is the cause of death. So we have to modulate, and especially very critical is the time of starting this kind of therapy. Of course, in a way you are right, because, you know, considering a general infection, you say, I give you immune suppressed drug as a cortisone, and how can I handle this? No, you have to choose the right moment, because you have to stop the inflammation cascade. Is the probiotics safe in preterm infant, in term infant? Yes. Some milks are enriched with probiotic? Yes. Best formula contains enough amount of probiotics? Yes. Generally, all the milk that contain probiotics get the CFU to have the effect. It is logical to use probiotics with antibiotics to prevent antibiotic-associated diarrhea? Yes, because they restore the flora. So yes, there are a lot of position paper and guidelines also for this. Is there any role of Lactobacillus reuteri in COVID? No. At what stage of pregnancy should we give probiotic? Can we use prednisone on positive case of COVID? Oh, wait. At what stage of pregnancy should we give probiotic? You can start since the beginning. Can you use the prednisone for any positive COVID, or only for severe case? Only for severe. Thanks, Flavia. Thanks to you. Is there any role of probiotic for cow milk allergy? Yes, I just showed, the last paper I showed basically is on allergy, but I like it because the process of immunity is almost the same. So we can give probiotics in addition to that milk. If the milk is supplemented already with probiotics, you don't need to give probiotics in addition. You have it already in the milk. If you use a breast milk or another milk that is not supplemented, then yes. Can healthy individual ingest probiotics? Yes, I do every day. Many criteria for the use of probiotic in human, we need 3 days congress. Next probiotic in pediatric will be 2021, so you are almost all invited. As we know, probiotic increases gas immunity and the COVID affects still respiratory. What is the role? None. I already answered to this. Is the probiotic enrolling constipation? No. Knee? Yes and no. Well, they can help, but they're not the treatment. What is the dose of reuteri colic in infant? 10 to 8. Colonic-informed unit. Thanks a lot. Could you tell us if reuteri is sold in pharmacies, under which name? I don't know about Iraq. So I don't know what's the market in Iraq in Jordan. I don't know. Does probiotic prevent or decrease neck in preterm baby? I send you back to this paper. Can be given prophylaxis in neonate? Yes. Most common side effect that occur using after reuteri? None. For how long can you use probiotics? Whatever you want the effect to be kept, you have to use it. Can early probiotic administration decrease the incidence of neck? Reuteri on neck has not yet been tested so far. There are a lot of studies. It's very effective on feeding intolerance. Can I chat with the professor? What's your opinion about use of probiotic at time of diarrhea? I told you this. Immediately, for the acute diarrhea, you start rehydration and probiotic. For how long we could use probiotic for infants of acute gastroenteritis? 7 days. Those probiotics decrease risk of gastrointestinal tract bleeding in preterm? No. Can use the prednisone of any positive? Only severe case. Always the same question. How long use? Oh, no, this is not a question. I take the any documented pediatric case of reinfection without COVID. Look, 3 days ago has been published in Nature a paper where is written that when a person get the infection of COVID, they produce antibody that are forever. There's no case of reinfection. You can have some swab positive again, does not mean is a reinfection. This has been published again 3 days ago. And I want to be clear. No, this I told you already. I told you already. I told you already. What is the frequency of in children and adolescents in Italy? The percentage is very low. No intensive care. This I already answered. Okay, almost finished.
I think we can take 1 or 2 questions more and then start our questions for the attendees.
Whatever. But I think there's any role of probiotic in immune modulation or treatment of IBD or celiac disease. For IBD, the position paper of Espgan say no, but there are only a possibility for the pouchitis in ulcerative colitis. For celiac disease, we are now doing a lot of study, especially because not to treat celiac disease, but to prevent the abdominal pain symptoms in celiac disease, the IBS related to celiac disease. Okay, almost done.